welcome also on behalf of the organizing committee of the Sub-Saharan Congenital Anomalies Network and the Global Health Network. It is my absolute pleasure as Secretary General of the International Federation for Spina Bifida and Hydrocephalus and as your moderator here today for today's seminar on the important topic of neurotube defects in the sub-Saharan Africa to welcome you. This seminar is the 8th seminar as part of a series of seminars organized by the Sub-Saharan Congenital Anomalies Network and the Global Health Network. And here you can see the program that we have prepared for you today. We have the pleasure to welcome 5 excellent speakers who will share with us today their expertise on the aspects of prevention and care for neurotube defects in South Africa, Botswana, Uganda, and Ethiopia. And also on the international level, we have been made aware during our 29th International Conference on Spina Bifida and Hydrocephalus previous month that healthcare, in this case for SBH, consists of many players where there is a need for dialogues across disciplines, collaboration, and above all, providing care which is accessible. So I also want to give compliments to the SSCAN network for facilitating these fruitful exchanges between the colleagues and countries. The meeting today is important and also, I think, an inspiring step forward for cross-country exchanges. And it is an absolute pleasure for me to be here today as your moderator. Before we start, there are a couple of housekeeping remarks. It is recorded, but also use the chat box for your introduction or let us know if there are technical issues, but mostly enjoy the presentations and post your questions in the designated Q&A box. There are also some comments for the Zoom controls, just so you are aware that your camera and microphones are disabled. If you would like to take the floor, and of course, if time allows, then please indicate so, and of course, use the chat function. For those who are new to the Sub-Saharan African Congenital Anomalies Network, you can see it here. I think what is very important is to see the primary aim of this network, which is really to improve diagnosis of congenital anomalies and care for affected children and families and promote the identification of their causes. We have today's webinar focused on neurotube defects with different perspectives, different champions of different countries. So I'm looking forward to a fruitful dialogue. For today's meeting, we follow a strict schedule, so I already apologize in advance, but I would say today's seminar is a starting point also for discussions afterwards. And then without further ado, it is my pleasure to welcome Professor Graham Fegan. Professor Graham Fegan is the head of clinical department, neurosurgery, Grote Schuur Hospital, a pediatric neurosurgeon, Red Cross War Memorial Children's Hospital. I know that very well, Professor Fegan, so it's a pleasure to have you here. Also as director of the UCT Neuroscience Institute, University of Cape Town, South Africa. So I want to ask you to start sharing your slides. And we warmly welcome your perspectives on this seminar's topic for today, and also from you as active champion for the SBH community in Cape Town in South Africa. But please, the floor is yours.
Fantastic. Thank you, Sylvia. On my slide showing there.
Yes, yeah.
Fantastic. Okay, thank you. Well, thank you very much. It's a real honor to be invited to be part of this amazing webinar this afternoon. And Sylvia, a real pleasure and honor to be introduced by you from an organization for which I have such respect and affection, the International Federation. So I'm a pediatric neurosurgeon, and we see, I guess, the vast majority of children who are born with neurotube defects first present with a neurosurgical issue that needs to be addressed. And I'm going to give you hopefully a bit of a broad perspective on the issues that are relevant in the initial management and then the long-term outcome of managing children and adults in many cases with spina bifida. So I think the most important thing to start with is it's the most common birth defect involving the central nervous system. And the key issue is that we're looking at conditions which, as the name implies, revolve around abnormal closure of the neural tube. But it's largely preventable. And I think that's probably the single most important point that we'll be talking about today. If you manage children born with typically spina bifida well, they can have an excellent quality of life. That initial management really has a profound impact on the quality of life. And we have a very important role, I think, all of us as clinicians advocating for these patients. So this is what a newborn baby with myelomeningocele looks like. The key thing here, as shown in this illustration, is what you're looking at really is the tip of the iceberg, and often there are other central nervous system abnormalities. But despite that, they can actually often have a really great quality of life and a very good developmental outcome. It's an ancient disease, as my title implies, and that really, I think, to some extent explains a lot of the confusion around the terminology of spina bifida. But actually, it's a very interesting condition in that there's been a massive escalation of interest, as you can see by the number of publications over the last few years. The challenges, I think, primarily revolve around the capacity to prevent spina bifida through folic acid and food fortification, making the diagnosis antenatally, and then picking up all the secondary complications that can occur, and then ensuring that there's adequate transition of care. I'm going to briefly touch on classification and terminology. So a few words about embryology and prevention. Briefly touch on antenatal management and then postnatal management. Tell you on one slide what we do surgically for these children, and then highlight a few key issues in the long-term management. So in clinical practice, we often refer to neural tube defects as dysraphism, and they can either be at the top end or cranial dysraphism, or at the bottom end, spinal dysraphism, and either open or closed. So open cranial dysraphism is anencephaly, which seldom is a clinical problem for us to manage. Most of those pregnancies terminate spontaneously or are terminated. Encephalocele is a slightly different issue that I'll deal with in a moment. But probably the commonest clinical problem with neural tube defects relates to open spinal dysraphism or myelomeningocele. Closed spinal bifida is much less common, and I'll touch on that briefly. And also, in essence, these do reflect different embryological mechanisms, either abnormalities of primary or secondary neurulation. So just one slide on cranial dysraphism. I've mentioned anencephaly. With encephaloceles, really the prognosis depends entirely on whether it's anterior or posterior. And it's very much location, 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 like buying a house. If you have an anterior encephalocele, the long-term prognosis is usually very good. Posterior encephalocele, very different story, and often very poor developmental outcome. One of the problems, though, of spina bifida is it's a condition that's visible externally, so it's been identified and described for many, many years. And there's an incredible abundance of very confusing terms used for it. At its most simple, spina bifida simply refers to a cleft in the spinous process of the lumbosacral spine. And pretty much 1 out of 5 normal people have that, and it's almost never clinically relevant. But in reality, when people talk about spina bifida, usually they're talking about open spina bifida or spina bifida aperta or myelomeningocele. Very, very occasionally, that may refer to spina bifida occulta, and I'll show you a few examples in a moment. But there are a whole bunch of other terms, and really the main point of this slide is just to illustrate the fact that there are lots of old and archaic and probably, in many senses, disused words that are used that can be very confusing. So when babies are born with myelomeningocele, there's an incredible array of appearances, from very small little lesions to extremely large lesions. But the common factor here is that the unneurulated spinal cord is visible on the surface. So that's open spina bifida. Just a quick word on closed spinal dysraphism or spina bifida occulta. Almost invariably, there's a skin abnormality. So although the skin is closed, there's either a lipoma or hemangioma, sometimes a hairy patch or dermal sinus or buttock atrophy. These are all different forms of closed spinal dysraphism. And their kind of central feature really is what's called a tethered spinal cord, where the spinal cord, because of the abnormal embryological development, the spinal cord has been held down, hasn't been able to develop normally. And that's usually the basis of the clinical presentation in these patients. So having covered very briefly encephaloceles and closed spina bifida, I'm going to spend the rest of this talk focusing on myelomeningocele or open spina bifida. So the embryology is terribly simple, and these diagrams that you'll find in any basic embryology book really tell the whole story. Closure of the neural tube by day 28, pretty much before the pregnant mom even knows that she's pregnant. And this process of primary neurulation accounts for 99% of the central nervous system. Part of the reason why this is such a complex topic, though, is that the caudal 1%, the bottom sacral and coccygeal elements of the spinal cord, develop by a completely different process called secondary neurulation. And there seems to be a kind of embryologically unstable junction that leads to all these different abnormalities developing. So as mentioned, neural tube closure happens very, very early, pretty much before the mum even knows that she's pregnant. And that's of critical importance if we want to talk about prevention strategies. Very, very, very briefly, neural tube closure is a complex business, and it's worth bearing in mind that there are many, many different genes involved. And I think the best way of understanding that is two important facts. One is that the process of neural tube closure is very conserved embryologically across many, many different species. So it's an ancient process. And as I mentioned, it's a complex process. And this micrograph from Lee Niswander's lab in Colorado, I think, shows very nicely the fact that it's a complex three-dimensional process. And I think anybody who thinks that one single gene or one single factor is going to be responsible for an abnormality in such a complex and biologically critical process, I think is perhaps oversimplifying things. I would refer you, if you're interested in the molecular biology of this condition, to this very nice review published last year, which really speaks to the interplay between various genetic factors and in the environment, with probably epigenetic factors being the sort of the final common pathway that links a lot of these different causative factors. There are many, many, many different genetic mechanisms that have been investigated. And once again, this diagram from the same article speaks to a number of the different genetic groups. But the single most fascinating aspect of this condition is the fact it's preventable, and preventable by a very simple strategy of a water-soluble vitamin of folic acid or vitamin B9. So folic acid can be taken either as a dietary supplement, or it can be actually added to food through food fortification, which we have in South Africa and many other progressive countries have. And I can't see any reason why any country in the world has actually not introduced this. This is such a simple and such an effective primary healthcare intervention that prevents a very complex condition. We have really actively taken up cudgels on behalf of folate, food fortification in organized neurosurgery, and are really hoping that the WHO reinvigorates their efforts to make this happen. And just to point out that even if a baby is born to a mum who's taken folic acid, the severity of the lesion is probably diminished. So it really is worth paying attention to folic acid antenatally or before conception to try and not only diminish the incidence, but diminish the severity of spina bifida. So I guess it often comes down to antenatal diagnosis, and particularly if one's looking at fetal interventions, you have to make the diagnosis obviously early enough. And in countries with sophisticated healthcare systems, usually pregnant women have diagnostic scans, etc., early on, which picks up the lesion. One of the most interesting aspects of spina bifida is the changing philosophy of management from a very nihilistic approach prior to the advent of shunts to what was considered a more selective approach in Britain in the 1970s, through to essentially a protocol of euthanasia in parts of Europe in the 1990s, and now in the 2000s, a very, very active approach to actually performing fetal surgery, which is obviously an extremely high-tech intervention. It does come down to making a diagnosis, and it does come down to proper genetic counseling and empowering parents to make a decision as to how they want to proceed with the pregnancy. But in well-resourced countries, and we don't have a fetal surgery program in South Africa, and in fact, there are very, very few countries other than extremely well-resourced countries that have fetal surgery for spina bifida. There is perhaps the case to be made. I don't want to wade into controversy here. As you maybe can hear from the way I'm describing this, I'm not convinced that we should be putting effort in here. I think we should be putting our effort into prevention. But there's no doubt that fetal surgery is a very hot topic in the area of spina bifida. Almost invariably, we see these babies when they're born. Very seldom in low and middle-income countries is the diagnosis made antenatally. And then you're faced with the challenge of preventing the baby getting infected and making sure you can close the back, ideally within 24 to 36 hours. If that doesn't happen, what may happen is that the neural placode may epithelialize or become infected. And we very, very strongly advocate that these babies have to have the chance of survival and good quality survival through early surgery. Delaying surgery and facing an infection like this is a catastrophe. I'm not going to try and take you through the surgery other than to say it's really simple. This is not a complicated operation. And in fact, in reality, most babies with spina bifida around the world are not operated on by pediatric neurosurgeons or even neurosurgeons, but oftentimes by medical officers working in clinics where they see lots of these babies. And the key thing is to close the dura. If you've got the dura closed and you prevent a CSF leak, you literally and figuratively are home and dry. And more often than not, these babies are going to make a good recovery from surgery. In terms of postnatal management, we're incredibly privileged at the institution that I work in Cape Town to have a very well-established and high-functioning multidisciplinary spinal defect clinic with a whole range of colleagues from different specialties that work together to ensure that we can offer these children as they grow up through childhood and into adolescence the best possible outcome. There are a number of different areas that one has to pay attention to, and I really want to highlight the urological complications specifically, and to highlight the fact that with clean intermittent catheterization, and I hope Sister Zubaydah Tofi, who's part of our spinal defect clinic, is part of this webinar. Zubaydah can maybe talk later about the incredible satisfaction of teaching parents under tremendously difficult social circumstances how to do this very simple intervention that can make such a difference to their children's quality of life. Hydrocephalus is something we manage in neurosurgery. I don't want to go into details here. Suffice to say that there are a number of different surgical interventions, and almost invariably children born with spina bifida, open spina bifida, are going to need management of hydrocephalus. The gold standard in terms of long-term outcome probably still is David McClone's series from Chicago. And what I'd highlight here is that 2/3 of children in the series were able to undergo normal schooling. And I really want to leave you with that real sense of optimism that if you manage children with spina bifida appropriately, they've got a really good shot at a fantastic quality of life and a good cognitive outcome, which means that anything is possible. Obviously, ambulation, walking is important, but it's not everything. And even if you're not able to walk and you have a good brain, you can achieve an awful lot with your life. But obviously, as you get older, it becomes harder and harder to walk, and we do see a drop-off in ambulation with age. As I've mentioned, we're incredibly focused on the fact that we have to advocate for these patients, and it's particularly gratifying to be part of symposia like this, where we have colleagues from a wide range of different disciplines who are interested in the topic of neural tube defects and preventing and obviously, when it does happen, treating children with neural tube defects. For those who are interested in more of the neurosurgical perspective, the International Society for Pediatric Neurosurgery has got a really fantastic online textbook, which is available free, called The Guide to Pediatric Neurosurgery. We've written up our experience in Cape Town in a supplement to the South Medical Journal, which you can also access free. And the take-home messages I want to leave you with, as I said at the outset, it's the most common major congenital anomaly of the central nervous system. It's complicated in terms of pathogenesis, but often preventable, and folic acid obviously is a key factor here. it should be diagnosed antenatally. And I think all of us have to redouble our efforts to make sure that in all our countries that women get access to proper antenatal care. When babies are born with spina bifida, it's mandatory to ensure that they have the best outcomes through early surgery, and then make sure that they get followed up in the correct sort of multidisciplinary way. To remember that all of us have an important role in advocating for these patients to ensure they have the best possible quality of life. And then not to forget that adolescence is difficult enough for everybody. It's particularly difficult for children with complex medical problems, and really to make sure that we provide the correct care to ensure transition of care. So obviously I'm very dependent on an amazing team of colleagues who help manage the patients we treat in neurosurgery. And on that note, thank you very much. I must apologize, I need to dash to the airport, but I will rejoin the meeting from the airport, and hopefully there'll be some exciting discussion a bit later. Thank you, Sylvia.
Thank you so much, Professor Fieken, baie dankie, as they say in South Africa. And I think it was an excellent overview presentation. And you showed really that there is no single solution for a multifactorial challenge if we talk about prevention or care. So thank you for showing that and sharing that with us, but also the importance of working together. Also with what you mentioned, Subaida, of the foundation of ASBA, representing persons with disabilities in Cape Town. We are aware of your time limit at this moment, so we will see each other very soon. The questions we will hold to the end of this meeting in the discussion session. Okay, then we welcome the next speaker, which is Ms. Modiegi Diseko. And Ms. Diseko is a trained nurse midwife with a Bachelor of Public Health. She worked as a midwife in government hospitals before joining the Botswana Harvard AIDS Institute partnership as a research nurse. Ms. Diseko, we look forward to your presentation where you want to focus on antiretroviral exposure in the Spina study. So we look forward to hearing the updates on your study.
Thank you very much. Good day, everyone. And let me just thank the organizers for inviting me to speak on the neural tube defect surveillance in Botswana. This is from 2014 to 2022. So in this talk, I am going to focus less on DTG and NTD, on those findings surrounding that area. And I'll be focusing more on our overall NTD results. Next slide, please. So in 2012 to 2013, when we were coming up with this concept of Tsepamo, Botswana had already rolled out the use of a tripler, which contains tenofovir, amitriptyline, and efavirenz. And it was used as first-line HIV treatment for everyone. So at this time, there were animal data suggesting that preconception of efavirenz was associated with CNS defects in monkeys. And we knew that we would get a large number of women on efavirenz at the time of conception. So the primary aim of the Tsepamo study was to evaluate the prevalence of neural tube defects with conception exposure to efavirenz in Botswana. So we did this by employing a birth surveillance strategy, where we performed surveillance at government maternity wards throughout Botswana. We initially started with 8 sites, covering 45% in the country. And then later in 2018, we expanded to 18 sites, increasing coverage to 72%. Currently, we dropped 2 sites because of some cost issues. So there are several factors which make the birth outcome surveillance strategy work well in Botswana. You'll find that more than 95% of women in Botswana deliver in a healthcare facility. And then again, the obstetric records the book that we carry, the record that contains each and every details about the woman's pregnancy, they are available at delivery, and then for more than 99% of women. And again, you find that there is no or minimal prenatal diagnosis or termination of pregnancies. So we do capture what happens to most pregnancies. Next slide, please. So the way CHAMPS works is that we first exclude any pre-hospital deliveries. So when the mom presents to the maternity ward and delivers a baby, the nurse calls our study team to alert them that a congenital abnormality has been identified. It has been noted during neonatal exam. So we confirm all deliveries by using the maternity logbook based in maternity wards. And we also confirm the key information on ARV information with women living with HIV. Then, at the time the mom is being discharged, the OB record is collected, the data from the OB record is collected, and the data is entered into a REDCap database. Next slide, please. So as for our procedure for collecting details on congenital abnormalities, the service exam is part of routine care. Through this, though we have provided training using WHO materials to the midwives as we started our study. And as I mentioned, when any abnormality is noted, the midwife contacts the CHAMPS RA, and the midwife is being credited for calling. The CHAMPS RA then goes ahead and consent the mother. And if the mother consents, she goes ahead and takes a photograph and description of the abnormality. For any case where we do not get a photo, the description is collected. Then the photographs of major abnormalities and unclear findings are reviewed by Dr. Holmes, who does this regularly, who is the pediatric geneticist. He remains blinded throughout to all exposures. So there are clearly some limitations to this surveillance approach. The surface exam, to start with, is really only able to evaluate the defects seen by the midwives. So we can't systematically evaluate for cardiac or any other internal defects. We also can't reliably collect defects that aren't evaluated on every infant. For example, the undescended testes, or even the hip dysplasia. Those ones are difficult because it's not collected in each and every infant. And some other abnormalities are very difficult to classify based on a photograph, such as club foot. We know that you need to do an examination, turn the foot around in order for you to see clearly where could be the defect be. And then, however, you find that neural tube defects are well detected using our system because they are almost always visible and difficult to miss. And then again, they are easy to photograph and not easily confused with other defects. Okay, now we go into the results. In our surveillance between August 2014 and August 2022, there were 236,195 deliveries at our CHAMPS sites. And then 99.8% had an evaluable infant surface exam and were included in our results. So we identified 162 NTDs, being a prevalence of 0.07% or 7 per 10,000 deliveries. So of these 103, there is 63% were diagnosed by a photograph, and the remaining 60 were diagnosed through description alone. The prevalence of NTD that we found is slightly lower than expected, given that the fact that Botswana does not have folate fortification of grains. I know Graham said that earlier about most countries having that, but Botswana currently doesn't have fortification of grains. So looking at the type of NTDs, 74, that is 46% were myelomeningocele or meningocele, that is 3.1% per 10,000 births. Then 38% of those were anencephaly, about 2.6 per 10,000 births. Then 15% of those were anencephalies. Encephaloceles, about 1.1 per 10,000 births. And 2 were in encephaly, and that is about 1 per 100,000 births. One of the defects was either in anencephaly or encephalocele, but because it was impossible for us to determine from the photo. I think the distribution of the defect is about what we expected overall. Unfortunately, these outcomes of infants with the NTDs was not good. There is 1/3 were stillborn, and of the remaining 108 live births, 38 of them died before leaving the hospital, that is 28 days or less. So we measured a perinatal mortality of 57%, but I should note that infants were not followed at the time after discharge from the hospital. So the true infant mortality is likely to be higher. Perinatal mortality is unfortunately higher among infants with NTDs. So we looked at the rate of NTDs per year per 10,000 births. As you can see here, we found a fairly wide range, as low as 4%, as low as 4 per 10,000 births in 2020 to 2021, and as high as 11 per 10,000 births in 2014 to 2015. Given the trend for lower NTD rates in later years, when we expanded from 8 to 18 sites, we wanted to make sure that we wanted to make sure that wasn't the reason for the rates being lower in the later years. So in the red axis, you can see that NTD rates in the later year for only the original 8 sites. And then while it is slightly higher, it doesn't explain the yearly variation too much. So we looked at the rate of NTDs per 10,000 deliveries by month of conception. Here, the black dots are overall, and the red dots are just the original 8 sites. You can see that the NTDs were highest in December, but also that there appeared to be a seasonal variation. Here is the late wet season, the early dry season, the late dry season, and the early wet season. And when we looked at NTDs per 10,000 births by season of conception, we found the highest rate of NTDs when conception occurs in the early dry season. That is, which is the coldest time of the year and the dry season in Botswana. Next slide, please. And then the lowest rates of NTDs occurred when conception occurred in late dry season, when the temperatures start to become hot, and it also it remains dry. And then we took this one step further, and we looked at the seasonal variation in high NTD years. When the yearly rate was more than 8 per 10,000, that is on the black dots, and then less than 8 per, and compared to the years when NTDs were lower on the red dots, that is less than 8 per 10,000 births. especially the peak in the early dry seasons only seemed to occur in years when NTD's rates were high. So this is as far as we have gotten with our NTD analysis. There are several questions that we would like to understand better, including why are we seeing the seasonal and yearly variation? Is there something environmental or related to diet or to other kinds of exposures in certain years and seasons? We also want to make sure there aren't any systematic ways in which we are missing NTDs using our system. Also, what other risk factors can we identify for NTDs in Botswana using our system? And also, of course, we are currently working on 8-year analysis of NTDs by HIV status and ART regimen, and we hope to provide those updates soon. As I mentioned earlier on, I didn't touch any relation or any association of these NTDs to ARTs. Thank you very much, and I would like to thank all people that were able to collect this valuable data. Thanks.
Thank you, Ms. Diseko, for sharing the outcomes of the NTD surveillance. And in your presentation, you also showed the challenges for infants with NTDs, but also relation with environmental factors. And that is very interesting. As we are awaiting the questions to arrive in the chat for this specific presentation, perhaps I already asked Dr. Madrid to take the floor to share your thoughts, because you're also experienced in the surveillance studies. Perhaps you have a question that comes to mind as a start.
Yeah, thank you. Thank you, Sylvie. Very nice presentation, Lina. Amazing work what you are doing in Botswana with this bird defect surveillance that we are really missing in many other African countries. I have just to be short, a couple of questions regarding the surveillance and trying to understand the low prevalence that you have found in a country without a food fortification program that we would expect a higher prevalence. And it's about if you are including abortions or even elective early termination of pregnancies in your surveillance, which is maybe one important thing that the surveillance approaches are missing. And the other is one problem that we have in Ethiopia, and I will explain it later, is the births occurring at home. And I'm not sure about the if you have this problem in Botswana. Your surveillance is hospital-based, and I'm wondering if how is the percentage of births occurring at home that maybe are somehow a way that we are somehow missing their NTDs and other birth defects. These are my two questions. One is about abortions. The other is about community births that can be also NTD cases. Thank you.
Oh, okay. Thank you very much for those questions. For the abortions, no, we don't. Our surveillance starts from 24 weeks and above, which means those that have abortions are seen in another ward. They don't come to maternity ward. This is because we know that congenital abnormalities at that stage, they are not clearly identifiable. That is why we start at where we know that this is a viable fetus. We are able to see it is fully formed. We don't capture any abortions. And then again, we don't capture those deliveries that happened outside the hospital side, because we are going to have some difficulties in analysis, because we have to know the correct denominator and the numerator for that, for you to be able to analyze and give the correct numbers. Yeah.
Great question so far. Huh? We already have another question, Ms. Diseko, in the Q&A. And that question is if you actually were able to measure also the blood folate levels in the population.
No, unfortunately, our study, we don't measure those, but we do collect information for any folate that was taken during pregnancies, which we are working on that, and we are still expanding that area in order for us to be able to analyze further and come up with good results. We don't do any bloods, because our study is not a follow-up study, it's an observational study where we look into the records and see how the mothers have been doing during their pregnancies.
Mrs. Seko, you mentioned funding is a challenge for this surveillance study. What is the time window that you are looking at this moment? Is this something you can continue in the upcoming years, or is the study coming to an end?
The fortunate part is we just got another funding. We hope to continue for the next 4 years. So we are hoping that with this 4 years, we'll be able to collect as much data that will be able to help with this NTD surveillance. Yeah.
Wonderful. Thank you so much. And I'm sure there are more questions coming in the Q&A, but we can always address them at the end in the discussion. Thank you so much.
Thank you very much.
Then we're going, if I'm not mistaken, we're going to the next speaker, Dr. Linda Barlow-Mosha. Is that correct? Yeah, I see it's already coming. Please, Dr. Barlow-Mosha, I will first introduce you. You are a pediatrician and senior investigator at the Makerere University, Johns Hopkins University Research Collaboration in Kampala, Uganda, with more than 15 years experience on this topic. You already have a track record with a varied portfolio of research that addresses different critical scientific questions in the pediatrics unit related to birth defect surveillance as well. You've also been involved in the development of international and national guidelines related to HIV prevention, but in this presentation, you will also make the link to neurotube defects from a hospital-based birth defect surveillance in Kampala, Uganda. We would very much forward hearing from your experiences. The floor is yours.
Thank you very much. So good afternoon, everyone, and good morning to those of you in the morning. I come to you from Makerere University, Johns Hopkins University Research Collaboration, and happy for the organizers to invite me. So I won't spend too much time on our first slide, but just a brief introduction. Uganda is the pearl of Africa, as you can see, right next to Lake Victoria. But in general, there's limited data on the prevalence of birth defects in Uganda and most of Africa. But with the introduction of new antiretroviral drugs and drugs in general in the clinical management of HIV, it remains important to collect data from pregnant women to evaluate the prevalence of birth defects. So in 2013, similar to our colleagues from Botswana, Makerere University and Johns Hopkins University partnered with CDC to initiate a hospital-based birth defect surveillance project in Kampala, Uganda. So the purpose of this project was to, one, establish a birth defect surveillance system and determine the baseline prevalence for major external birth defects in Kampala. And together with this, we had a nested case control study to examine the association of maternal use of antiretroviral therapy and birth defects, very similar to our colleagues from Botswana. And our surveillance project included 4 hospitals in Kampala, which captured about 55% of all births in Kampala. This slide here shows a systematic review that was done in 2016, and it looked at the neural tube defects prevalence worldwide by region. And what you can see at that time in the Africa region, there were only 2 publications that were present that provided prevalence data from Algeria and Tanzania. And what they showed was the median prevalence was about 11.7, but there was a wide range between 5.2 and 75.4. But we know that more data has come since then. And what I wanted to point out here on this slide was also the proportion that is expected, the distribution of NTDs, what you typically find is approximately 50% would be spina bifida, 40% anencephaly and craniorascus, and 10% encephalocele. And anencephaly, again, is very rare. So the objective of this analysis is to describe the birth outcomes and the prevalence of NTDs among infants and HIV-infected women on ART, as well as infants born to HIV-negative women in this hospital-based birth defect surveillance program. The 4 hospitals that were included one very large government national referral hospital, which has approximately 30,000 births per year, and 3 faith-based hospitals, which are private, not-for-profit, and each of them has approximately 6,000, but altogether 18,000 births. So we were looking at approximately 48,000 births per year collected in this surveillance program. So today, I'm going to present data from 2015 to December 2020, and looking at the maternal demographics, HIV status, the birth outcomes that were evaluated, which include all live births, stillbirths, and spontaneous abortions, regardless of gestational age, that were extracted from the database. And similar to our colleagues in Botswana, we also do photographs and drawings, take narrative descriptions of all the defects that occurred during that time. And these drawings and narrative descriptions are reviewed by the local team, as well as a panel of experts at CDC for confirmation and classification. We calculated the prevalence of the birth defects and also looked at the association of NTDs with HIV. So this slide here shows us our findings. During that time, we had a total of about 170,000 births from 164,000 women with a median age of 26 and a range of 20 to 30. But our age, the median IQR of 20 to 30. Our oldest woman was 59, and I think the youngest was about 12. We had an 8% age prevalence and for HIV infection, with 95% of them on antiretroviral therapy, So in regards to the type of antiretrovirals, what we see here is that our women were primarily on efavirenz-based ART. Very few were on nevirapine, atazanavir, and at the time, dolutegravir was not rolled out yet not rolled out in high volume in Uganda. We only had about 1.6% that were on dolutegravir. And when it comes to timing of ART, we see that about 65% of the women were on ART before conception or during the first trimester, and the rest were initiated during that pregnancy. This slide here shows you the types of neural tube defects that we were able to see. You can see that altogether, we had actually 164 neural tube defects, but 7 of these babies had 2 defects, so they're only counted once. So you see here a total of 157 infants affected with a prevalence of 9.2. In regards to the most common type of neural tube defect, you can see that spina bifida was the most common, followed by anencephaly, encephalocele, and then the 2 that are rare, craniorascus and anencephaly. I pointed this out here just to show you that these babies are born both live and still. You can see that with anencephaly and craniorascus, we did have a few that were born live, but most of these babies died within the first 24 hours because these lesions, as we have seen, are pretty lethal. In regards to those born with encephalocele, you can see that 85% are born live. And the same goes for spina bifida. Very few are born either stillborn or have a spontaneous abortion. So this slide here shows you the prevalence of all the different subtypes. And you can see from Dr. Graham's presentation that we have all the different subtypes of encephaloceles and anencephaly in spina bifida. But again, the most common in regards to spina bifida were in the lumbosacral region. And in regards to encephalocele, we had both frontal and occipital lesions seen. So this slide here shows us the prevalence and compares the HIV exposed to HIV unexposed. What we do see is that among those who were exposed to HIV, the prevalence was 10.7 per 10,000 live births, and those among the unexposed was 9. However, there was no significant difference in the NTD prevalence when we compared the two groups. One case was excluded due to HIV unknown status. So we pointed this out just to show the variability of the prevalence that we have seen over time. And it's a pretty busy slide, so I'll take some time to explain. The blue shows you Mulago Hospital, which is the National Referral Hospital, and the pink is the faith-based. And what I didn't mention earlier is that we initiated the surveillance in a phased manner, where we started off at the bigger hospital and started rolling in the smaller hospitals, Mengo and Zambia and Rubaga. And as the numbers grew, so did the prevalence. The other interesting factor that has also been presented by Ms. DeSecco is that we also do see that variability, and this is by quarter, when it comes to how many neural tube defects we see over time. And the blue line here is the trend, and you can see the even trend. Now, unfortunately, due to COVID, we did have to stop our surveillance for some time. So we do see a drop in our prevalence, but we hope that this will level out with time as we continue on with our surveillance system. But we point this out just for those who are starting off on their surveillance to know that there is some variability, and it's important to follow these trends over time. So this last slide really talks about risk factors for neural tube defects, and it's leading into our next presenters. We know that there are established risk factors, and the primary one being folic acid, as well as B12, and other factors, including anti-epileptic medications, gestational diabetes, and obesity, and other more rare ones. But there are also other suggested risk factors. And we're going to go into a risk factor analysis very soon in our surveillance project, where we'll take many of these into consideration, and primarily looking at smoking, at least on our part, to see if that plays an influence on some of what we're seeing in Uganda. But again, folic acid insufficiency seems to be the greatest driver for neural tube defects in most populations. So in terms of what we've been able to show in our surveillance, we have a paper out that really describes our surveillance project. We've also been able to describe the challenges that we've overcome, trying to roll out the birth defect surveillance in the different hospitals. We've also taken a look at adolescents and compared the perinatal outcomes with older women, if you're interested in that. And finally, but not least, is the use of a mobile tablet to collect the data, which makes it simpler than collecting it from paper files and allows the team to look at the data in real time. And currently, we're looking at a qualitative study that's going back and talking to the women and healthcare providers to get their views on birth defects and address issues of stigma, as well as address issues of care. Do these babies go to get care thereafter once they're diagnosed in the hospital, as well as a few others that we're hoping to present. But this is the paper that describes this data in more detail, in birth defects research publication in February 2022 of this year. So what are the implications for the Uganda program? Basically, as our previous presenters have said, neural tube defects are a common defect in Kampala, and these findings are similar to the current prevalence rates from other sub-Saharan African countries. We've already seen the Botswana team that have just presented. ART for us was not associated with an increased risk of NTDs, with women on efavirenz containing regimens as their primary combination antiretroviral. But now with dolutegravir being introduced, and we've already seen the numbers change in our data set, where the primary antiretroviral now for pregnant women is dolutegravir, will be able to contribute and provide more data for ongoing birth defect surveillance. So this analysis, I must stress, did include only a few women on dolutegravir. So we really need to continue with the birth defect surveillance and hope to provide updates after collecting data for this year, 2022. So I'd like to thank the participants and all the contributors to this work, especially our colleagues in Makere and my colleagues at CDC Uganda and the Atlanta team and the hospitals where all this work is being done. Thank you very much.
Thank you very much, Dr. Bala-Moshe. And it seems that we already have 2 questions for you in the Q&A. One question is if you also know from your work of the surveillance study about the survival rate of live births with NTDs.
No, similar to our group from the SAPAMO study, our study is also designed with only follow-up from birth to the time of discharge. However, we have received funding for the next 4 years as well, and we're hoping to add some element of follow-up to at least maybe get some data on 1 year survival. We have yet to implement that in our current protocol, but we're hoping to be able to provide some information on survival as well.
It's good to hear that the protocol is expanding and you have the opportunity to proceed in the upcoming years. Huh? Yeah, there is another question. If you think that women are referred to the hospitals in your study when they have antenatally diagnosed NTDs, or do you think this prevalence of NTDs is likely to be similar all around the country?
Okay, as I said, one of our hospitals is a national referral hospital, and there is some element of referral, but most of these NTDs are not diagnosed prenatally. They're diagnosed at birth. There are very few women who actually get an ultrasound according to our data. So there's, you know, if they're referred, they may be referred for other reasons. And the fact that it is a referral hospital, we do not include those born outside. It's only those that are born within the hospital, because that would also give us a skewed prevalence rate. In regards to, do I think this is the same rate nationally? I think there would be some differences, especially looking at different regions, be it due to environmental issues or nutritional issues, and even antenatal care issues. But again, as part of our expansion, the program is going to expand to other regions within Uganda. So we'll be able to look and see if the rates are similar in the northern, eastern, and western. We're primarily central regions when we do the expansion over the next 4 years.
That's very good to hear. And I think looking at the questions, most probably they are coming also in the discussion. There is one related to iron folate consumption. If you have evaluated the frequency of iron or folate consumption in your work.
Not so much. However, we do ask if they took folate. And I have to say that about 70% of women show up in the 2nd and 3rd trimester. And that is when the folate acid and iron is given in antenatal. Very few are actually on it prenatally, but as we've heard from our first presenter, the window is closed for that pregnancy. So any folate taken during that time would not have any effect on the pregnancy. The defect would have already occurred. So it's an important piece, and I think it would affect future pregnancies and not so much the pregnancies that we see based on the population habits of seeking antenatal care. I did not present how many came in the first trimester, but I believe it's less than 15% who actually come in the first trimester. And when you look at adolescents, it's even less. It's closer to 7% that come in the first trimester for antenatal care.
There are good questions, and perhaps for the discussion, you may want to share with us your visions of combination of collaborations in Uganda, how we can strengthen surveillance on multiple levels. But for now, thank you so much, Dr. Ballo Masha, and we will continue now to the next presentation by Assistant Professor Lola Madrid, who we already saw in the previous presentation to raise a question on surveillance. Yeah, Dr. Lola Madrid, you are a pediatrician and epidemiologist, so you also have experience on this topic of epidemiology, but you have experience also in different regions, South Africa, Mozambique, Ethiopia, Guinea-Bissau, and other countries, but as a clinician, as a researcher, focus on different elements of health. So this presentation, you will fully focus on CHAMPS, surveillance network programs, and we look forward to hear from your experiences in Ethiopia.
Thank you so much, Sylvia, for your nice introduction. I'm working in the last 4 years in Ethiopia, leading there the child health and mortality prevention surveillance, which is the CHAMPS network, which is a project that I will explain later on in my presentation in detail the objectives, but basically it's trying to understand causes of death in stillbirth and children under 5 in an accurate way using postmortem sampling. And we are trying to assess, especially to identify preventable deaths. And in Ethiopia, we found NTDs, one of the main causes of death in our site in Eastern Ethiopia, that we were not expected at all. So we are now through CHAMPS trying to expand that the research area on NTDs due to that funding. So I will explain a bit the prevalence of neural tube defects in sub-Saharan Africa, Eastern Africa, and more specifically in Ethiopia. The prevalence by subtypes that were explained by our colleagues before, but more specifically in Ethiopia. One of the main problems that we are also seeing is like a mortality attributed directly to neural tube defect based on our CHAMPS data, and then some conclusion and challenges with the current estimate, and at the end, what else we are planning to do in Ethiopia to overcome this problem. Let's start a bit with some data on overall data on neural tube defect. There is no real data on neural tube defects, prevalence of neural tube defects worldwide, basically because those countries with the highest prevalence, or where the highest prevalence is estimated, lack of robust birth defects surveillance system that can provide that information. But there is some works, and this meta-analysis is one of them. Is one that really show the estimate overall in the world. So we have here, we just focus in sub-Saharan Africa. We have here data on countries with folic acid fortification, and before folic acid fortification, we see that the prevalence is in sub-Saharan Africa before folic acid fortification was 1.5 10,000 live births, and data based only in one study in South Africa was a bit lower, around 1 per 10,000 live births. These are only estimate, but in this meta-analysis, only 6 studies from sub-Saharan Africa were included, which is not the best option to do overall estimates. This is the same paper showing similar data, and we see here that sub-Saharan Africa is the 4th WHO region with the highest prevalence for neural tube defect. I'm bringing this figure because this is the case, the distribution by age, starting by abortion, stillbirth, under 5, and survivor over the age of 5. And if you see here, there is no abortion considered in sub-Saharan Africa. And there is some previous work saying that around 50% of NTDs are abortion or stillbirth. And in this data, looks like there is no almost abortion. So likely these data are underestimated. Let's focus a bit now, narrow a bit the scope to Eastern Africa. This meta-analysis, including data from 6 different countries, show an overall prevalence of 33 per 10,000 births. And Ethiopia was the country with the highest prevalence, around 60 per 10,000. And it included, in this systematic review, 9 papers. If the same paper trying to understand the trend over time in the prevalence. And we can see that there is a trend over time, that there's an increasing trend over time in the last decades, probably due to lack of publication in the previous decades. I don't think that this trend is not completely real, it's more related to lack of previous data. These are the papers included in this work in Eastern Africa. And if you see, most of them are hospital-based, and there is only 2 that are community-based. The problem of the hospital-based study is some people think that these data are overestimating the prevalence of NTD, because usually hospitals are somehow collecting children or are attracting children with complicated conditions, and NTD is a complicated condition, and likely is somehow overestimating the real prevalence. However, most of these hospital-based studies are not considering stillbirth or are not considering abortion. Then the true prevalence is not well known. And now in Ethiopia, what is going on regarding NTDs? These maps show different papers publishing different data on prevalence in the different regions of Ethiopia. In orange, we have Tigray, which is the whole region, and a city in the eastern Ethiopia, that is the city where we are working, in Harar, with a prevalence over 100 per 10,000 births, which is very, very high. Followed by another paper in Diredawa, which is a small city, in Addis Ababa, the capital, Amhara region, and Oromia. There is a few regions that they don't have any single publication with data on prevalence of neural tube defect. But anyways, in all cases are quite high, the prevalence. And the pool prevalence is 63 per 10,000 children, which is quite high compared to other places. And there is a systematic review meta-analysis done in Ethiopia showing this data on prevalence. And most of them has a high prevalence, reporting a high prevalence of neural tube defect in the different regions. The problem is that most of them are cross-sectional studies. Only one cohort study is hospital-based, with showing a very high prevalence, the highest in the country reported so far in the north of the country. But all of them are hospital-based. And Ethiopia is a country where there is still a lot of community births. There is some regions with 40–50% of births occurring at home. And these are missed by all this publication. And on the other side, if you see here the study population, most of them are newborns. All of them are alive babies. So these studies are missing also abortion and stillbirth. The real scenario that we have in Ethiopia is the true prevalence is unknown because there is no well-established birth defects or NTD surveillance. And when we see by type, my colleagues in previous talks have explained the different types of NTD. I will not go through it again. And in Ethiopia, we have seen a few papers published are showing similar funding, and encephaly spina bifida are the most common NTD cases reported, but we have a higher prevalence of anencephaly in a few papers published. As I was explaining before, the study that I'm leading in Eastern Ethiopia, CHAMPS, is a mortality surveillance. And we are trying to understand cause-specific mortality that can be attributed to specific conditions in different countries. And I need to, so just reviewing a bit publication, there is not appropriate data on mortality attributed to a specific neural tube defect in the country or in sub-Saharan Africa. So just very briefly, what is CHAMPS? It's a child health and mortality prevention surveillance working in 7 countries, active countries. There is a few countries that are probably will be enrolled very soon. The idea is to understand causes of death by taking post-mortem sampling. We are taking sample, we are taking photographies, we are taking clinical information, verbal autopsies, and using advanced microbiology and pathology methods to understand the cause of death of children and stillbirth, and trying to use that information to inform policymakers to use the data for actions. These are the methods. I will not go in detail to that, but we are trying with all the information available for each case. And I was saying that include clinical information, microbiological information, pathology, and also photographies. We are assigning the cause of death, not only one specific cause of death, but we are trying to understand the chain of events, underlying cause of death, comorbid condition, and immediate cause of death. Using this system, we have done an analysis for the first 4 years of the surveillance in all sites, and we are trying to understand birth defects and neural tube defects in all sites. In these 4 years, in the first 4 years of the surveillance, we have found more than 3,000 deaths that are already has already a cause of death identified, and among them, 10% were birth defects, which is this like a dark pink pie. So, and these are birth defects. Around 10% of all deaths that have a cause of death identified. Among them, 69 were neural tube defect. So some conclusion and challenge with the current estimate and what we are thinking to do. So the conclusion is that the prevalence in Ethiopia is much higher than in other countries worldwide and in sub-Saharan Africa. The problem that we have is that all data in Ethiopia are hospital-based and likely are overestimating the burden of NTD among children that are born alive. But we have a scarcity of data in abortion and stillbirth, and likely there is an underestimation, an overall underestimation of the data. And the conclusion is that the true prevalence is unknown for all these problems that I have explained above. So what CHAMPS is trying to do after seeing those alarming data of neural tube defect and mortality associated to NTD in Ethiopia, especially in the catchment area where we are working. We are now working to implement an NTD surveillance at population level. And we will be able to do that using the CHAMPS platform, the mortality surveillance, but also a pregnancy surveillance that we are also running in the same site, door by door. So meaning that we are working in hospital health facilities, but also at the community level, covering 3,100 people. And we will be able to understand the true prevalence at population level in that catchment area because it's a well-defined population. This surveillance will generate data before and after a well-established mandatory food fortification program is implemented in Ethiopia. As I said before, there is already an approved mandatory food fortification program in the country, but the food vehicles selected were not the best because of lack of appropriate coverage. And I think that my colleague Marisa from Ethiopian Public Health Institute will explain that better in the next talk. The experience that we will get with this NTD surveillance in Eastern Ethiopia may serve as an example to implement surveillance across the country. This is important because Ethiopia is really suffering a real epidemic of NTD, I would say, and we really don't know what the true prevalence. We are also working with the main hospital in the area, which is a referral hospital, to create a multidisciplinary team to improve the care of NTD cases. There is already a neurosurgery unit, but we need to create this multidisciplinary team that Dr. Graham was explaining before to improve the quality of life and the outcome of those babies. And we will do also some qualitative research trying to explore feasibility and acceptability of a food fortification program with fortified salt. Dr. Marresha will explain later the plan with this project because it still needs to be validated as a food vehicle, and community perception on neural tube defect and the stigma associated to those cases. And that's all from my side. I'm happy to respond to any question that you may have.
Thank you so much, Lola Madrid, for this overview, because Ethiopia, on many levels, you are working hard to indeed have an idea on the prevalence, also ideas on what is happening with the mortality rates and how can we reduce that. And I see there's already a question from Linda. Please, Linda.
Thank you, Lola, for that wonderful presentation. You mentioned that there are some other countries that are joining on board. We're wondering which countries are those, and many of us are actually doing surveillance, but mortality is one of those things that we really love to know, that what happens to these children once we have counted and calculated the prevalence. So how do you think other regions or other countries can get involved in the CHAMPS network if there is a possibility?
The CHAMPS network is not static. Now are 7 countries working. In fact, it started in 2016 with 1 country, another country were joining. And now there is a few countries more, Nigeria and Pakistan, that are in contract process to be added. There is somehow a selection process done by the program office of CHAMPS, which is the University of Emory University, and they are the one somehow reviewing the potential new sites based on first national mortality. It needs to be a country with a high mortality over 50 per 1,000 births. Is usually births is the threshold. So 50 per 1,000 is still a high mortality. And if there is a demographic surveillance system that somehow we need to understand denominators and being able to extrapolate data at population level on causes of death are some of the requirements. Usually it's Emory University, but I can ask Linda and give you more detail on how more sites can be part of the network over time.
Okay, thank you.
Lola, I was wondering, because you mentioned the future studies, that you are thinking about qualitative research. And I'm sure that Dr. Tesma will follow up on that from the perspective of folic acid and fortification and consumer behaviors. How could the qualitative studies also support the identifying the high mortality rate in this case?
In fact, CHAMPS is a very difficult study. We are doing post-mortem sampling using minimally invasive tissue sampling in the first hours after the death. And especially there is country like Ethiopia, in the region where we are working, is a Muslim population that has usually a very quick burial process after the death. So we are already working with the community for 5 years now to understand community perception on causes of death and trying to do formative research on how important to make them part of our project, and for them to understand how important it is to understand causes of death. So the community is already involved in CHAMPS. We have a lot of what is called public involvement, community engagement, community involvement. Otherwise, it's impossible to do a project like CHAMPS if we are not working very close to the mortality. So as I was saying, we are this mortality surveillance as well as a pregnancy surveillance that we are doing, and the entity surveillance that we want to do is a project that we are working at community level, facility, but also community. And the community level is a project we are receiving that notification from the community. We have influential people, religious leaders, women leaders, different kind of influential people that are part of the community that are notifying us deaths or are notifying us pregnancy, and then the team will go there to do all the study procedures. So we are working very close to the community to make them understand the importance of this surveillance, and they are part of it somehow.
Yeah, thank you. Yeah, I see there are multiple questions coming in now. We will address one more, and then we move the rest for the questions to the discussion, if you don't mind. There's one methodological question I see in all your studies of your systematic meta-analysis presentation were cross-sectional and did not report abortion or stillbirth. So what is your recommendation for further and supplementary research?
Yeah, so these are not the studies that we did. That was a review that I did on the studies published in Ethiopia and other, like Eastern Africa. So the recommendation that we want to do with our surveillance is trying to include all those missed cases by other groups. When you are focused only in hospital or cross-sectional study, you are missing a lot of population. And this is what we want to do. So for how we will overcome this problem in our surveillance, we have a pregnancy surveillance in Eastern Ethiopia. It's a pregnancy surveillance working in 20 health centers and 3 hospitals, but also at community level. We have midwives that are working as field workers, knocking doors, door by doors, trying to find pregnant women and trying to link them to the health facilities. Through this pregnancy surveillance, we have allocated 1 ultrasound in each health center that is done for free, and a midwife has been trained on do the ultrasound, and they are also detecting neural tube defect during the ultrasound early in the pregnancy in that first visit. So this is how we are trying to detect abortions, to detect NTD intrautero, and also stillbirth, and that will somehow overcome other data already published that didn't include this kind of cases.
Thank you so much, Lola. And we are moving now from you to another colleague who will then address more the folic acid, the fortification, nutrition, and prevention in Ethiopia. So I warmly welcome our last speaker, Dr. Mashresha Tessema from the Ethiopian Public Health Institute in Addis Ababa in Ethiopia. And for the introduction, you are the director of the Food Science and Nutrition Research Directorate in the Ethiopian Public Health Institute. So following Dr. Madrid's presentation, we very much look forward to hearing from you.
Thank you, Sylvia. Hello, everyone. Greeting from Ethiopia. Indeed, being the last presenter is very difficult, but I will make it very short. So my presentation, as it has been already introduced on the neural tube defects and mainly on the proposed solution in Ethiopia. So, some of the background related with, the neural tube defect has been already presented by, earlier speakers. As we all know, the neural tube defects, which is the most common birth defects, which mainly occur in the first 28 days of pregnancy. And this has also been presented. There are 3 NTDs which mostly common in Ethiopia, including anencephaly, Spina Bifida and Hydrocephalus. These are the most commonly reported NTD cases in Ethiopia. It has been also said, from literature, we understood that the risk factor for the neural tube defects are categorized in general in three. The process of NTD has, multifactorial origin and have also a significant genetic component. And the first one is which we call gene environment interaction. And the second one is related with maternal health. And the third important point, which I will be speaking also related with nutrition or low folate intake, is the most important risk factor for the cause of NTDs. So in Ethiopia, some of the available evidence in terms of NTDs, we found or we know that low consumption of iron folate rich food in Ethiopia from the National Food Consumption Survey. We do also have an evidence that the coverage of IFA or iron folate supplementation is very low. I can say below 10%, even with the recent data. Even the timing of IFA is also mostly start late initiation, as you see. Mostly the NTD will occur in the first 28 days, where almost all mothers could not recognize their pregnancy. And it has been spoken, with a number of speakers in today's presentation. Folate is an important nutrient, especially for replication of DNA. And we also understood that, especially the red folate or red blood cell, RBC folate, which we call it, is a long-term folate status, as well as the serum folates, which are mostly considered as a marker or an indicator of neural tube defects, as well as the megaloblastic anemia. With this understanding also, we have an evidence in Ethiopia that, from national studies, that high folate deficiency among women of reproductive age, as you can see that at national level is around 40%, or at sub-national level also there is a small variation, but you can see the problem exists in all regions in Ethiopia. If we estimate this in absolute numbers, about 11 million of women of reproductive age in Ethiopia are low folate status. And with this figure also, we try to model the risk of neural tube defect from that data, and we found that almost majority, or about 84% of Ethiopian women, are at risk of neural tube defects. And you see in some region, even almost all women are at risk of, Afar and Harar, and some other region, almost all women are at risk of NTDs. In relation with this also, we try to see also the other, global evidence, compare the NTD prevalence with Ethiopia. You see that even though, the data we have is population based, when we compare with many African or other country, the prevalence of NTD, as you can see, for example, in Addis Ababa, it is 6 per 1,000 bars. In Tigray, as has been mentioned by Lola, it is also very high. It's about 40 per 1,000 bars, which is also very high compared with many African countries, which is about 1.7 or 2. So considering this, there has been also, as we said, Ethiopia is one of the countries which we have a significant achievement in terms of reducing infectious disease such as malaria, HIV, and other diseases. However, like many African countries, the birth defect is becoming the most significant cause of child mortality and major public health problem. And we also do understand in 2010 also the global, the World Health Assembly, or the 63 World Health Assembly adopted the resolution for member state country to mainly focus on prevention of neural tube defect. So considering this, the Ethiopian government produce a number of strategies as prevention strategy, including the IFA, pilot adolescent, folate supplementation, and some dietary approach. Very recently also, the mandatory wheat flour fortification. As part of the treatment also, the training of pediatric surgery, also part of the program where the government is working in. There are indeed also other programs where, currently the government is doing. With this understanding and this problem, in 2018, the Ethiopian Public Health Institute received the request from the Ethiopian neurosurgeon as well as from the Federal Ministry of Health, to find at least a solution. And following that, we developed a policy brief, and this policy brief come up with a number of recommendations. Some are from existing evidence, some are from expert, opinions. And we all understood that there is a very strong evidence, like, preconceptional folic acid supplementation is the most, recommended or immediate intervention to prevent NTDs. However, as we all know, mostly pregnancy is not planned. And we do also understood that, large-scale food fortification program largely reduce, NTD by half. And there is also a number of evidence globally. As you can see also, for example, in Ethiopia, the food, the fortification of wheat flour consumption is, very low. With the expert come, some of the innovative opinion, fortifying iodized salts might be the best strategy to overcome, because salt coverage is very high, and salt could also be addressed irrespective of socioeconomic and cultural status in Ethiopia. However, the evidence is lacking in terms of double fortified salt, and so we propose studies. Maybe this could be a best solution, a best vehicles. And we have also a number of reasons why we selected salt or iodized salt could be a potential intervention. I would mention only the three. The first one is because of the self-sufficiency of salt production in Ethiopia. The second one is also salt is mandatory in Ethiopia. And for example, if you take the iodized salt coverage in Ethiopia is over 90%, which is nearly achieving universal target. And the third or the final justification is fortifying iodized salt with folic acid could have high impact. It has also low cost, as we all know. And you see some of the recent data where, the salt coverage, the iodized salt coverage in Ethiopia at national as well as at sub-national level. So with this regard, what is known and what is not known is, for example, and there are a number of issues which we didn't understand. The first one is sensory trials of the salt with iodine and folic acid, which is not known. And we have already conducted for this study, and our result is in the analysis stage. And the other issue which is not known is also stability of folic acid. When we add folic acid on in addition to iodine, we should study the shelf life, and this also not known. The other important one is also the efficacy of salt fortification with iodine and folic acid, which in turn, lead to reduction of NTD is also not known. So the most important one, also the implementation modality is also not well understood. So considering this, we will have a two-phase studies, and which we mainly do this study on the women of reproductive age. And we have also selected the study which is near to Addis Ababa, which the district which you call Gimbichu district. Our first phase is mainly a kind of preparatory, studies looking at, dietary intake of folate, which also measure a number of biomarkers, including the RBC folate and serum folate status. We do also measure other nutritional factors, including vitamin A, vitamin B12, and other B vitamins. On the second phase, which is we call the community-based intervention trial, based on the first intervention or the first phase of studies we will conduct, the second phase. As you can see, we will have three phases or 3R. I'm sorry. And the first one is iodine. And the second one, which is low folate status. And the third one is with high folic acid. As you can see from each arm, we will have recruiting 120 women of reproductive age. And as you can see from the outcome, we will have, you know, a number of outcomes, and most importantly, we'll focusing the change in folate status. And we do also consider the safety of folate. And the intervention, as mentioned, will be delivering, you know, salt on bi-weekly basis, about 500 grams of salt. And as mentioned, in addition to the intervention, you know, the project has also other components like, you know, the introduction of iodine, folic acid, salt that include also the value chain analysis and the marketing analysis, industrial capacity development, and also the feasibility testing in order to large scale production, and as well as, you know, the market introduction are another component of the project. With this, I thank you everyone for listening, and thank you.
Thank you so much, Dr. Tessema, and compliments for the ambition for Ethiopia to work so well on prevention on the many levels. I am looking in the chat and the Q&A to see if there are specific questions to your presentation. If not, I will ask a first question. The salt fortification studies are currently going on, huh? So that means that your country is investing to see if that could be effective, and it shows from the preliminary studies already that there is a lot of potential in there. Could you share with us how well does the Ethiopian government at this stage understand if salt fortification is something we can move forward? What are the barriers or the perceptions of the communities to consume fortified foods with the salt?
Yeah, thank you. Indeed, you know, thank you for that question. And then in terms of iodized salt in Ethiopia, is we can say is over 80 or 5% or nearly 90% of the salt is having iodized salt, which indicates that almost we can say it's a very successful program. So we want to follow the same procedure or add, you know, folic acid, you know, with already existing system. In terms of anticipated challenge, when we add folic acid, there might be a number of challenges. The first one is, you know, convincing the policymaker, you know, to add folic acid as a mandatory legislation. That is the most important challenge, which we should, everyone would work on that. And the second one also related with the industry, you know, knowledge, and also in terms of implementation, this could also be maybe another important challenge in terms of implementation. But some of the challenge which we could not predict, but some of the challenge which we already knows. Yeah, thank you.
Do you expect any challenges from pregnant women to consume it, or do you say no? At this moment, we only see barriers on regulations.
Yeah, we might see a challenge not only from pregnant women, from everyone in the community, but as much as if you could do some advocacy works, you know, awareness creation, I don't think that will be a problem for the women if they could understood. Yeah.
Good, thank you so much. I'm looking in the Q&A. Okay, there's no specific question to now, but on that note, thank you, Dr. Tessema. We have come to the discussion and we are very much on time. So thank you to all the speakers for keeping track of the time here. You can join me here on the floor, please. We have a couple of questions that can be shared for the full panel. I'm looking if Professor Fegan is already here. No, he will join us later then. Ms. Diseko, there was a question specifically addressed to you. In view of your infants are not followed up after discharge, I invite you to contact us to share with you our management and support of the mother with their baby born with spina bifida. That's a comment from Zubaida from South Africa. I don't know, Ms. Diseke, if you want to respond to that. Okay, we may have a technical challenge here. Dr. Lola Madrid, there was a follow-up question from your systematic review reports. How do you perceive and comment on the high heterogeneity?
Yeah, that's true. It's a problem of this kind of meta-analysis. The problem is the quality of the data and how the different ways to do these studies in the country. And it's a problem, as I said. So how we perceive, we need better data. And this is what we are trying to generate. This is what I can say.
And that's not easy because you already showed the challenges when knocking on doors and the efforts that go into that. Yeah. It seems that Dr. Tesema, there's a good question coming in the chat to you. The question is, I think the main factor in the success of the fortification is the rate of consumption before and during early pregnancy. Do you think that in addition to the campaigners, the stimulation by local ambassadors, such as school teachers or the church, might have stronger influence on consumption than a national campaign? What do you think?
Thank you. Indeed, those influential people are always very important. It could be teacher or whoever, are always very important. We understood. For us, once we come up with a very strong evidence, and the rule could be mandatory, so it is must for everyone to have, iodized plus folic acid salts in their home. So with that understanding, I don't think we will have a problem, because it is illegal to have non-folic acid and non-iodized salt at home. With that understanding, I think we will solve our problem.
Yeah, thank you. Sorry, I had the Q&A box overlapping in the screen. There is a question from Hesselberger, and it's very good that that we have the panel here, because I think different views might be there from different countries, different perspectives. The question is regarding possible dietary environmental risk factors, such as the exposure to mycotoxins, secondary metabolites produced by foodborne fungi. At some stage, it was suggested that fumonisin B affect the absorption of folate by disrupting the folate receptors. And this scenario could be especially relevant to mice subsistence farming communities. And the question is if this is still considered as a possible contributing factor. That might be interesting from different communities and different, difficult to answer perhaps, because we have different specialties here. Okay, I see Dr. Tissema.
Yeah, in terms of, understanding the etiology of, NETDs, largely the literature says environmental factor is the most important factors, like exposure to, some heavy metal could, inhibit NETDs. I mean, the folate, absorption that may lead also NETD, but largely I think the evidence are lacking. We do also in our policy brief, which we developed also, one of the recommendation is to explore, the proportion of NETD contributed by environments is the most important, even with Lola's and CHAMPS team, because the area is highly exposed to some chemicals, like pesticide that might also be contributing to high prevalence of NETD, so that required further studies or research. Over to you.
Yeah, Dr. Madrid, perhaps you have another idea?
Yes, well, no, I was just explaining, the continuation of Mazresha's comment. Yes, so we have many environmental factors that can impact the mothers and how, and then impact the prevalence or burden of NTD in our area. And we are planning a study to understand that a bit better, understanding exposure to different pesticides and other kind of maternal factors beyond the folic acid deficiency, that it will be, of course, maternal exposure that we will explore. So it's something that is in our program, in our plan to do.
Good that there's so much attention to environmental factors. So Dr. Barlow, Marcia?
Yes, I just wanted to add that we also have a nested case control study, and within there we'll look at environmental factors. Very soon we'll be able to share the analysis from there to see. We haven't specifically looked at mushrooms, but we'll take a look at that.
It already is a proposal for a second seminar to follow up on this. I was wondering about the commonalities. When listening to your presentation, you hear a lot of overlap in terms of the surveillance, understanding, barriers. I also wonder in what way could countries learn from each other in the approach? Are there any thoughts on that from you, Ms. Diseko? In what way could we perhaps see the commonalities and learn from each other's work to implement better on the prevention strategies and care, perhaps? You are muted, yeah.
Thank you very much. I think it's a matter of collaboration and sharing our findings, coming up with ideas on how to help each other, and looking at how we can broaden the surveillance. Yeah, and then on the fortification part, and for our surveillance, we are working on looking at how the association, like if we supply our mothers with multivitamins and folate, and then compare to those that have not received, and see if at all how will be the occurrence of these outcomes and NTDs included. Yeah.
I think Dr. Barlow may want to respond to that. Yeah.
Yes, I think collaboration really is key, because these defects are so rare. So being able to work together and maybe even do some pooled analyses might be very helpful. So hopefully in the future, and that's one of the visions of SCAN, is to make sure that we have international collaboration in different sectors coming together to answer some of these important questions.
Yeah, in terms of sharing expertise, Dr. Madrid, you mentioned a lot of different obstacles your group has overcome to conduct surveillance work. I can imagine that there are participants here present that do not have a surveillance study going on in their countries, or perhaps are thinking about it. Are there some lessons learned that you may want to share?
Yes, of course. And the main lesson learned, I would say, is to involve the community. If we don't involve the community in our research work, it will be very difficult to get good data. So to get acceptability is very important. At least for us in Eastern Ethiopia, it's a very difficult community, and we need to work with them. We need to somehow engage them and have them make them part of our research work. So this is the main thing that we learn. The advantages that we have is CHAMPS is a very difficult project. As I said before, we are doing postmortem sampling in the first hour after the death. So the first step to build that surveillance was to establish a very strong social science team to do qualitative research in the area. And this social science team was working 1 year before we started to do the proper mortality surveillance and take the clinical samples. And the work that they are doing it didn't stop there. They went there, they were working with the community, trying to understand community perception on causes of death. Now we are trying to understand community perception on NTD, stigma related to NTD, how the community would accept a food fortification program. All these things needs to be understood and very, very well before moving forward with further research. Otherwise, it's very difficult to be successful somehow and to build good surveillance with high quality data. So this is what the main lesson learned, and it's not a work that stops before research. It needs to continue over the time during the research, doing community engagement things. So we are doing a lot of activities, community services, theater for development, drama, trying to make them understand through drama what are the main causes of death. So radio program, many community activities to engage the community. This is the key lesson. And of course, after that, trying to reach to the grassroots level to get data, not only at facility level, but also at the community. That may vary somehow in different contexts. In our context, many things are still happening at home, deliveries, deaths. So if we don't work at community level, we are missing half of the cases, of 30–40% of the cases. So it's very, very important to work with the community.
Thank you so much. And on that note, perhaps a final thought or recommendation from Dr. Balamosha for the participants that you want to share?
Yes, on behalf of SCAN, really, I'd like to thank all our presenters. I think we've had very engaging discussion, not only on the causes, but also on prevention. We hope that the work continues and we're able to collaborate and inform people further on the importance of neural tube defects, as well as the importance of preventing neural tube defects, which is the most common birth defect that we tend to see across the world. Thank you, Dr. Sylvia.
Thank you, and it is indeed common, and we know what to do in the prevention and the care. Perhaps an inspiring final comment from Ms. Diseko.
Okay, no, I just want to say thank you very much, and we are hopeful that with this collaboration and the SCAN, we are going to learn more about this birth defect. It's not only birth defects, neural tube defects, but other major birth defects which affect the outcome and the mortality and morbidity rate. So we need to come up and work together in order for us to come up with strategies to reduce all this, working to improve our babies' lives, our infants' lives. Yeah.
Thank you. Dr. Tessema, a final comment?
No, thank you, everyone. And I think every one of us, this Eastern African country, I think each of one can learn each other. I think there are many things from Ethiopia's side in the coming years where, some evidence will be out, and we're happy to share anytime. And indeed, also we'll be learning from our colleagues from Botswana, Uganda, and others. I think, yeah, we can learn each other. And thank you, Sylvia, for organizing this. And yeah, thank you, and have a nice day.
Yeah, thank you all. And we have come now really to the end of this 8th seminar on NTDs. Compliments again to the organizing committee of the Sub-Saharan Congenital Anomalies Network and the Global Health Network. Thank you for inviting me to be your moderator for today's important session. I want to thank all the participants because you have been very active today in this meeting. That's much appreciated. Thank you especially to the speakers for sharing your expertise, your knowledge on NTDs and sharing the country's perspectives and continued commitment that you show to improve prevention care for persons with neural tube defects. And your presentations really emphasize the need for continued collaborations because there's no single solution to multifactorial challenges. We hope that these presentations then also inspire the work in your countries wherever you are tuning in from today. And I think, Dr. Balo, in your remark, this seminar could be a stepping stone for further discussions following hereafter from your network in this SCAN, and we welcome certainly the collaboration with the network as international federation. So thank you all, and stay healthy and well, and looking forward to seeing you next time.